I want to welcome everybody tonight. I'm Diane Bowen. I'm the founder of Golden Isle Center for Plastic Surgery, as well as Centered on Wellness. And this is our quarterly installment of our approach to whole person, well person health. And it is my pleasure today to present a topic called Happy Mouth, Healthy Heart, because this is February, which is a Happy Heart Month. And so without further ado, I'm going to hand it over to my two colleagues, Dr. Samual Norris and Dr. Jim Greene. And since I'm telling you, Dr. Norris will give you all of his credentials, but he is my periodontist, and that is credential enough for me.
My name is Sam Norris, and I am a periodontist in Brunswick, Georgia. I've been in practice for 15 years, although it doesn't seem that long. Educational credentials, as Dr. Bowen mentioned, I went to dental school at the University of Mississippi, and I completed my periodontal residency at the Medical College of Georgia, which has changed names several times since then. A little bit about the different areas of dentistry, because sometimes people are somewhat surprised to know that they're dental specialists. I think most everyone knows if you want to have braces, you go to an orthodontist. But I've listed all of the ADA recognized specialties of dentistry. You have public health, endodontics, they do root canals, oral and maxillofacial pathology, which is kind of similar to a medical pathologist in a lot of ways. Oral and maxillofacial radiology, kind of similar to a medical radiologist. Oral and maxillofacial surgery, orthodontics, pediatric dentistry, periodontics, and prosthodontics. Of course, I'm next to the last. Surprisingly enough, there is no recognized specialty in cosmetic dentistry. There's no recognized specialty in TMJ, and there is no recognized specialty of dental implants. But a little bit about periodontics or periodontology. It's the specialty area of dentistry that deals with prevention and treatment with problems that affect the gums and the bone that holds the teeth in place. So what I'm concerned with is the foundation of everything. And even though most areas of dentistry are kind of procedure driven, periodontics prevention, both before and after treatment, is a very important aspect of a successful outcome. What is periodontal disease? Gum disease, pyorrhea, trench mouth. They're kind of all names for the same things, but it's an infection that occurs below the gum line that damages the bone, destroys the bone that holds our teeth in place. The last sentence I'll kind of modify a little bit. It says periodontitis can cause teeth to loosen or lead to tooth loss. It always does, given enough time. Every study on untreated periodontal disease, the result is tooth loss if you follow the patients long enough. But a little slide that kind of shows what's going on with periodontal disease. The dark stuff that you see here is calculus, or more commonly known as tartar, which we all have tartar buildup on our teeth despite our best efforts. Yes, they scrape when they clean my teeth too. Tartar above the gum line is not so much of a problem. When it gets below the gum line, that's where things can become more concerning, because it's hard to remove through a regular cleaning, and then you can see all these wigglies. There's a lot of bacteria that lives in the tartar. The bacteria that lives in tartar is a little different than what causes tooth decay, but the bacteria produces toxins, and then it initially will cause ulceration of the gum tissue that lines the crevice in between the gum and the teeth. If your gums bleed when you floss or brush, that's what's going on. And as far as the heart relationship, we've now kind of have a microscopic open wound for bacteria that is in the mouth to enter the bloodstream. Some x-rays, radiographs of a patient that has periodontal disease. I get to look at these things every day. But the red line that you're seeing is how much bone has been lost. The blue line is where the bone should be. Of course, if you look at this slide right here in the middle, these two teeth have developed a nice gap. The bone support is, really diminished, and the teeth start to move. But X-rays are an important part of diagnosis, of course. But when we look at X-rays, we want to see where the blue line is. Unfortunately, a lot of patients I see, it's where the red line is, or even further away. This is an example of a really healthy mouth. A clinical exam, if I'm looking in a patient's mouth and I see this looks really, really good. Teeth are clean. The gum tissue is very pink. It's firmed. You can see how nicely the gum forms triangles in between the teeth. If you have a nice triangle, most of the time the bone level is good for the gum to be high. No inflammation or redness. This is picture-perfect dental health. This is a patient that has plaque on their teeth. And we all develop a bacterial film every day called dental plaque, or more now it's kind of called biofilm. But it builds up on our teeth every day. It's not dependent on whether we've eaten or not. Just like we get mildew in our shower because it's a wet environment. Some people say, well, I hadn't eaten anything today. Well, plaque forms 5 minutes after you brush, plaque starts to form again. It's a never-ending cycle. But you can see the yellow, the orange fuzzies near the gum line, and then you can see a little bit more redness, especially on the top teeth, where the plaque has been there, and it's starting to cause inflammation of the gums due to that bacterial response that we talked about. Plaque has to be left on the teeth 36 hours for this to happen. If we could perfectly clean our teeth at home, which no one can, if you could get all the plaque off, you would only have to do that once every other day, and things would be really good, like the first slide. Unfortunately, we all fall short. But this is a little diagram about how periodontal disease happens. Plaque on the teeth leads to gingivitis. A lot of people are a little confused about gingivitis versus periodontitis or periodontal disease. Gingivitis, the gums are inflamed. We have not lost any bone yet. Periodontitis, the gums are inflamed and we're losing bone. The plaque leads to gingivitis, even more redness. And then with periodontitis, we actually have bone destruction. Now, gingivitis is a reversible condition. Teeth are clean, gums get healthy. Once you have periodontitis and the bone loss starts, it's the point of no return. It'll never get better by itself. It'll only get worse. Now, the little bottom two words, that's an important thing too, because you have to be susceptible to developing periodontal disease. Some people never progress from gingivitis to periodontitis, even though they do nothing to take care of their teeth. Their hygiene is terrible. Their teeth may rot down to the gum line due to cavities. They never lose any bone. They're kind of fortunate in that regard. The other side of the coin is someone can do a pretty good job and they're very susceptible and they have periodontal problems. But anytime you see redness, swelling, kind of like the circled area here, chances are, there's going to be, bone loss on the x-ray. And that kind of shows the amount of bone destruction that's present on this patient. Of course, this is an advanced case of periodontal disease, black tartar on the teeth. The gums have receded a lot. When the gums are lower, the bone is much lower. A patient like this, the 4 front teeth could not be saved. You could probably pull them out with your fingers. Anytime a patient says, "Hey doc, my teeth are loose," I have a feeling I'm going to give them some bad news. But the interesting thing about our teeth and the gums and the bone is that it's the only place in the body where we have an appendage that's sticking through tissue. I mean, the closest thing, it might be our fingernails, but that's a lot more sealed than the gum tissue around the teeth. This is a person that's missing all their teeth on the top, completely sealed off. You know, what's underneath is there's no exposure to all the bacteria that's in the mouth. Now, a patient like this, where you can look and say, hey, that doesn't look exactly right. If we were to get all of the bacteria out of their mouth that's under the gums, and we injected it into a mouse, it would kill the mouse. It's pretty toxic. Now, periodontal disease most of the time is not going to kill you, but there are some pretty bad bugs that are involved. So the association between periodontal disease and heart disease, it started back in 1989 with a physician from Finland named Dr. Mattila. And he just kind of noticed that he was actually a family practice physician. And he said, you know what, a lot of my patients with heart disease have bad gums and bad teeth. He said, you know, this kind of seems to be a little bit more of a coincidence. And so he actually wrote the very first paper, not by a dentist, but by a physician, about an association between dental health and heart attacks. So a few more papers followed. Some in the United States, and you know, the dental community kind of got on board and more research was done. Of course, the periodontal community became very interested in this. Well, in the early 90s, teeth made the cover of USA Today, you know, which was exciting, you know, that you don't normally see teeth in the lay press that much. But, you know, they had an article on it, which was a really heightened awareness. A little while later, Time Magazine had an article about inflammation and all the diseases associated with it. Well, periodontal disease, got 2 sentences in that article, which is a lot more than dentistry gets in the lay press. But they did mention that it's important to floss your teeth because it reduces chronic inflammation, which is true, despite the Surgeon General's report a few years ago. By 2003, we had, you know, a lot of authors that had published studies, you know, on the link between periodontal disease and heart disease. By 2005, there were double that number of articles. So it was kind of picking up steam. Now, I was already in practice at that time, but this is an interesting study that was done that said, well, you know, what does this bacteria do in the bloodstream, and how can we quantify it? Well, they had a group of patients, some with periodontal disease, some that had healthy mouths, and they had them chew a stick of gum 50 times on each side, gentle chewing. And they drew blood from both groups, the healthy group versus the periodontal disease group. There were 10 times the level of endotoxins in the blood with the periodontal disease group. There was a little bit in the healthy group, a little bit. Not bad though, but there 10 times more just from chewing with the periodontal disease group. But with heart disease, of course, one of the major things are plaques in the arteries, or atheromas, as it's called. You know, unless the artery is totally blocked, they're really not a problem unless they rupture. But our thought is that maybe these bad bugs in periodontal disease can stimulate the inflammatory response that can cause them to rupture. But to believe that theory, they had to determine that these arterial plaques actually had periodontal bacteria in them. Well, sure enough, you know, they did 8 or 9 studies. Every one of them came back positive for periodontal bacteria, which normally only occurs in the mouth in these arterial plaques. So that was pretty good evidence. This is kind of a microbiology slide as far as what's in the mouth. This not everything in the mouth, but it's a lot of things in the mouth. We have our the red ones over on the right. Those are some of the notorious periodontal bacteria. Now they're kind of more in the family of tetanus, botulism, more so than staph strep. But this was a mid-90s study that did a lot to isolate periodontal bacteria, and it kind of laid the groundwork for the previous study about the bacteria and the plaques, about, hey, we know where these bugs come from. But other studies have shown that CRP, interleukin-6, PNMs, those are all inflammatory markers that can be measured in the blood. When those are elevated, healthcare providers say, hey, this is not right. Even if you don't have a major disease, we don't like those numbers to be out of whack. But there have been several studies that show the more advanced the periodontal disease, the more raised the inflammatory markers in the blood. If you're getting that type of evidence just through a blood test, what is it doing to other organs in your body? So we know that all of these problems on the right, heart disease, Alzheimer's, rheumatoid arthritis, periodontal disease, asthma, some diabetes complications, arthritis, osteoporosis, obesity, they're all related to inflammation. They're all inflammatory processes. So then we were kind of able to connect the dots and say, hey, how do these two kind of fit together? Some additional studies were done that showed that having periodontal treatment to eliminate the periodontal disease was proven to lower the inflammatory markers in the blood. Now that doesn't mean that you won't have a heart attack, but it's still an encouraging finding. Another study with more aggressive periodontal treatment showed the same thing. Now historically, most periodontal treatment has been aimed at helping people keep their teeth. That's what my primary practice mission is. Not that I don't do some other things. There are some other things that I'm involved in, but I want to help people keep their natural teeth. If you can help them be healthier overall, well, that's certainly an added benefit. About 7 or 8 years ago, the organizations of cardiology and periodontology got together and they said, hey, we've had a lot of evidence. There have been a lot of studies that are pointing that not a cause and effect relationship, but there's certainly a lot of correlations between these two problems. And what we know now is that there's certainly enough evidence to acknowledge the link between the two. Even with some of the common risk factors like smoking, with periodontal disease, the incidence of having a heart attack or a stroke are about 2 to 3 times higher than if you didn't have periodontal disease. But to kind of cap it up, what we have is plaque on the teeth, risk factors, tissue destruction, you throw in some bad habits like poor oral hygiene, smoking, we get severe periodontitis, and that can increase any systemic inflammation that already be there. Plus, they don't have much to eat with. And then we come up with the secret killer of inflammation. Diagnosing periodontal disease is actually pretty easy. A third-year dental student could do it. Most of my patients that I see have been referred by a general dentist. Not that you have to have a referral to come see me, but some questions to think about if someone has periodontal disease is, do your gums bleed? Do you have any loose teeth? That's a big one. Do your teeth look longer? Do you smoke? That's a red flag. Not that all smokers get periodontal disease, but a lot of them do. How often do you clean between your teeth? What are your oral hygiene habits? And have you seen a dentist in the last 2 years? Now, I have plenty of patients that have been seeing a dentist religiously. they weren't the highest risk candidate to develop periodontal disease. Sometimes, negative things happen to people that were doing everything right. But a little slide with pictures to kind of summarize how all this is linked together. But I thank you for your attention. And
Okay, thank you. Jim Greene, I'm a family physician, and I'm delighted to do part of this talk. How do we transition from the mouth to the whole body, or in fact, what we're primarily talking about is cardiovascular disease. I can tell you my paradigm for treating cardiovascular disease has changed over the past 2 years. I didn't realize there was a huge link between mouth bacteria and cardiovascular disease until recently. But a Sentinel article came out in 2017 that is actually saying that there are at least 5 pathogens, maybe more, that are actually causal for atherosclerosis. And to me, that Sentinel article was an eye-opener for me. So I'm appreciative of being invited tonight just to at least overview a little bit about atherosclerosis and taking the things Dr. Norris has said and putting them together in our world. So at the very end, we'll answer questions, and perhaps both of these talks will at least allow us to think a little bit more deeply about the oral systemic connection with cardiovascular disease. And I provided a few handouts, and basically we can start out with thinking about what is atherosclerosis? What does it really mean? How do we get atherosclerosis? And there are 3 primary things that have to happen. You have to have lipids in the body, and there has to be a certain amount of those lipids. And the bad lipids, we've all heard of LDL. It's actually more than just LDL, and we call those lipids ApoB or ApoB. And those are divided into several components: LDL, LP(a), IDL, and VLDL. So you have to have those components in the blood to consider the development of cardiovascular disease, atherosclerosis. Beyond that, you need an inflammatory response, or you need endothelial dysfunction. So the lining of the artery, the intima, needs to be exposed or injured. That's the second part. And the third part, you need to have those lipids somehow make it into the lining of the artery, and they're oxidized or changed, and they stay there. Well, they form a plaque, and that plaque is atherosclerosis. How can oral bacteria get in the bloodstream? What do they do to help participate in the formation of this plaque that we call atherosclerosis? As mentioned earlier, you can have an endotoxin that's produced. The bacteria, just with actually talking, chewing, brushing your teeth, certainly going to the dentist for cleaning, can allow these bacteria to get in the bloodstream. And enough of those, particularly these 4, 5, 6, 8, and we may find more pathogenic bacteria, produce that endotoxin, or the amount of them produce an inflammatory response. That inflammatory response either opens up the endothelium, that intima, and those bacteria send signals of inflammation that respond particularly We see those with toll-like receptors. We see those with interleukin-6. We can look at HSCRP, or C-reactive protein. We see that there's an increased inflammatory response. White blood cells come into that area to try to protect the area. Well, along with that, smooth muscle cells inside the middle part of that artery, the media, transition to a secretory type, and they allow a connection between a positive and negative, a positive protein, the lipoprotein, the negative proteoglycan, and a positive apolipoprotein B. So they're connected and they stay. They form foam cells, and they form this atheroma, or a bump on the inside of the artery. We can see that bump over time build up as those lipids are oxidized and changed, and they stay. Funny thing is, you can have a normal lipid panel and have a heart attack. At about 25% to 30% of the time, the first time a person has their heart attack, they come and they have normal lipids, their blood pressure is normal, but all is not well because there's been an inflammatory response. And even if you do a cardiac catheterization, you may find that they don't have a narrowing significant to put in a stent or be bypassed. Acute coronary syndrome presents about 25-30% of the time as an erosion. So that plaque develops along the lining of the artery, but also on the interior, and it erodes the lining, denudes. That plaque is exposed, forms a clot, and that clot fills the vessel or moves down to a smaller area. About 75% of the time, the plaque will rupture. So there's two main different types of atherosclerosis that's going to cause an event in a heart attack or stroke. So the reason that the dental portion is so spectacularly novel, because most of us in our general medicine practice really haven't heard the word. There are many causes for inflammation. Dr. Norris mentioned many different types of diseases. There's 2, 3, maybe as many as 500 different styles of diseases that cause inflammation, and we can list those, certainly. Diabetes, probably the first are pre-diabetes, smoking, high blood pressure. The list goes on your handout. Genetics could play a part as well, does play a part as well. You can have the good cholesterol, HDL, may be dysfunctional. It may not work. That's another reason. Sedentary lifestyle, being overweight. We mentioned tobacco. So numerous things that can precipitate the development of inflammation. So it's intriguing that we have come from 20, 30 years ago thinking that LDL was the main problem, the bad cholesterol was the main problem causing this atherosclerosis and the cardiovascular event, to learning that inflammation is really the cause. That inflammation can be brought about from many different factors, and about, I'd say 25-30% of the time, periodontal disease, endodontal disease is going to be the culprit. So we can get our lipids down. And from my standpoint, what do I do when I see a patient? We can look at lipids, wonderful. We can look at the diabetes, we better. We can look at blood pressure, and we better get that under control. But if we don't look inside the mouth, we are not doing a service for our patients. Let's see. So this is just some of my general thoughts. What do I do to work up a patient? We need to make sure that they have a well-controlled blood sugar. That doesn't mean that their fasting blood sugar is 100, less than 100. It should be much lower, believe it or not. That doesn't mean we check a hemoglobin A1C, that average blood sugar. We want it less than 6.5, or do we? Really, we want it about 5.4% or so. Do we look at blood pressure? We've all heard 120/80 is excellent. We probably want it a little bit lower. Heart rate even can be a risk factor, or can be a red flag for cardiovascular disease as well. So we look at a lot of different parameters, and we screen. We also use inflammatory markers. With my practice, I have the luxury of ordering labs from specialty companies like the Cleveland Heart Lab or True Health, and we go beyond the normal CBC, or complete blood count, a lipid panel, and a liver and kidney functions, and a hemoglobin A1C. We will look at markers that actually correlate with periodontal disease, like the LPPLA2. If there's a high LPPLA2 and everything else is fine, you better look for periodontal disease, because if you treat periodontal disease, the LPPLA2 will go down. So will those other markers. HSCRP, we order that. There's another one called ADMA. There's another one called fibrinogen. We can order an insulin level. So we go beyond just the normal standard labs that we've all had. It's a delight to be able to start looking deeply for the causes of atherosclerosis. It's the #1 killer. Every 43 seconds or so, someone has a heart attack. Every 4 minutes, someone dies from a stroke. So our goal in primary care is to look at every risk factor or every root cause that we can uncover, so that we don't have our first heart attack or stroke. I think that's all I wanted to do, is just stimulate folks' thoughts about the oral systemic connection